for having me today. My name is Brian Tallant. I'm a program director at the Aurora Mental Health Center. I run a clinic there called Intercept Center, which is the only clinic of its type in the state of Colorado, which works exclusively with youth that have developmental disabilities as well as mental health conditions. I also sit on the board of directors for the National Association for the Dually Diagnosed, and also am on the IDD expert, the Intellectual and Developmental Disability Expert Panel for the National Child Traumatic Stress Network. And I'm here today to talk to you about serving basically one of the most underserved and probably poorly served subpopulations in the state of Colorado, which is people with intellectual and developmental disabilities. I think I'm going to start out by talking a little bit about what has worked in small pockets in Colorado, and I think our clinic is an example where years ago, when the capitated system was created, when we started a capitated system, the behavioral health organization in our area was very unique, and it was created by the community providers. And I say that's significant because when we started to look how a managed care system could be viable, we had to understand how to get inpatient costs under control and divert those funds to good preventative care. And one of the things we realized is there were a small group of youth in our community that were utilizing a grossly disproportionate amount of emergency care and inpatient care. And the one thing that group of youth had in common is they had intellectual and developmental disabilities in addition to their mental health issues. And their mental health issues primarily was trauma. We had a system of care group. We didn't call it that at the time, but that's what it was. It was basically community partners, stakeholders around this population who said, let's get together. The school district had great self-contained classrooms for kids with developmental disabilities, but they didn't have psychiatry and family supports. It was needed to get those kids stable. The mental health center had great day treatment programs for kids with mental health issues, but they were not healthy environments for kids with intellectual and developmental disabilities. So basically we got together with the school district mental health center and piecemealed this thing together and created this day treatment program that we needed. We started with about 8 kids that were probably the highest utilization resource utilizers in the entire community. We figured out, and actually, our goal at first was pretty meager. It was really to maintain these kids out of the hospital the best that we could in order until they aged out into adult services and could access really intensive integrated care like the regional centers or something like that, which we don't have for children. What we discovered is that if you had good structured behavioral programming with a challenging academic curriculum, you had good family supports with linkage to resources in the community, you had adapted psychotherapy for the kids' developmental disabilities, you had accurate psychiatry and aggressive psychiatry who specialized in the population, those kids recovered, they got better. And they got so well we could transition them out to a less restrictive setting. We could get them back to their home schools, which was the birth of our outpatient program. And we started to work simultaneously with the school district to identify these dually diagnosed kids early so that we could get them into outpatient care so that hopefully down the road they wouldn't need higher levels of care such as day treatment or residential, which is, as you heard just recently, the residential crisis, especially for this population, it's a crisis. But what I want to really point to is that in the last I've been with Aurora Mental Health Center running this clinic for 23 years. I've been on every dual diagnosis task force the state has created in the last 2 decades. And the problem about underserving this population has not gotten better, it's gotten worse. The various state departments have been aware of the issue, yet nothing has really changed. And one of the reasons I want to point out is because people think that what I do is a clinical expertise, but it's not a clinical expertise. I never learned a thing about dual diagnosis in my schooling and my training. Everything I learned came from a family member, or came from a parent, or came from a person with a developmental disability. This is not a clinical expertise. This is a cultural competency. The people with intellectual and developmental disabilities is it's a disempowered minority in our community. And it's a disempowered, and the one thing that makes this disempowered minority unique is it's the only disempowered minority in our community whose minority status is defined by a medical diagnosis. And that medical diagnosis is used by our healthcare system to discriminate access to behavioral health care. So in other words, if you contact your community mental health center, you contact your BHO, which is now our array, and you say, I have a developmental disability, or you just go into a community mental health center and request an assessment, what you get is somebody who says, well, we really don't have that expertise, and they'll send and refer people off to the community center boards. that don't have any mental health service providers. I mean, could you imagine that if we had somebody who came in and said, you know, I'm gay and I need mental health services, and the community mental health system said, oh wow, we don't have any specialists in gay and lesbian issues, but I heard there's some gay organizations that you could go to and you should get your mental health services there. Or if somebody came in and said, I'm an immigrant and I need mental health care, and we said, oh wow, we don't have immigrant specialty services, so we don't know how to serve you, so but I heard that there's some immigrant services down the street, you should go there and get your mental health care. I mean, we wouldn't do that, but the fact that this minority has a medical diagnosis that defines their minority status, we use that as in our healthcare system to discriminate against them, and they don't have access. And the issue has not gotten better over the years, although we've been aware of it. We have acknowledged that dual diagnosis exists, but then we get into these crazy discussions about primary diagnosis. And I want to introduce you to this concept of, oh, wow, that was fast, of diagnostic overshadowing. And that is an over-attribution of the mental health symptomology to a person's disability. I want to introduce you to the idea of a healthy person with a disability, which is an oxymoron in most of our understanding about disability, and especially in the mental health industry. And there are solutions to this. I mean, and trauma is the other issue. The biggest issue facing this population is trauma. We know in the research that people with developmental disabilities experience 2.5 times to 10-fold the amount of abuse and neglect as people without disabilities. So the need is there, and people are being turned away and they're being sent to systems that don't have mental health supports. And we can fix this. We have to get away from a diagnosis-based reimbursement system and go to a needs-based reimbursement system. Getting away from, I know we're shifting to more of a fee-for-service sort of model and getting away from sort of the capitation, which I think is not going to be good overall for the community mental health system, but I think it's going to be uniquely helpful for this population, because a resource-intensive population like this is seen under a capitated system as a resource drain. And what happens is there's a financial incentive to use that medical diagnosis to discriminate, with that financial incentive not to serve them. And maybe that'll change. Maybe under fee-for-service you'll have a situation where if a person needs concrete and repetitious therapy 3 or 4 times a week and they get it because you can bill fee-for-service for that, then maybe that'll change. I have other ideas about, we have changed with our HIMAT laws in Colorado. If you have private insurance, there's mandates for serving people who have autism, but we haven't done that with our public system yet. We haven't created mandates. The only mandate I'm aware of is that you can get services if you have a diagnosis of autism up to the age of 6. And the mental health needs of people with autism go beyond age 6, and they go on into adulthood.